Hello, everyone. This is Paul from Ortho Eval, and the first thing I'm going to start with today is I want to apologize for blowing my first webinar. Okay, and I knew this would happen because technically I'm not very savvy. Can talk all day about all kinds of stuff, have great content, but when it comes to electronics, I just don't do a spectacular job at that. So I promised you a webinar. I'm going to give you a webinar. Unfortunately, you can't shoot the questions to me live right now, but you can definitely download this, look at it. I'm going to send you the PowerPoint that goes with this. And then if you have questions, then you can send them directly to me on my email, and which you should have now that, that you have received these links. And so so happy to be able to do this for you today. Today, we're going to be talking about lumbar spinal stenosis. It can be pretty loaded, can be a very difficult diagnosis to treat. But most importantly, you want to get a good evaluation on these patients. And then I'm going to give you some really good treatment techniques today that if you're going to succeed with somebody who has lumbar spinal stenosis, this really is going to be the way to do it, and in a conservative way. And then we're also going to talk about, if they don't respond conservatively, where do you go from there? What do you do, and how do you treat these types of things? So please feel free to send me all kinds of questions and comments about this and other topics. I'm getting really excited about a program that I want to start called OEP Select, which means that this will be a membership only program where you're going to get webinars like this, and also some consultations with me if you would like. We're going to be offering all kinds of information, some research, evidence-based stuff, and lots of kind of more exclusive information for folks. So that's going to be coming down the road. So I hope you get excited about that, because I sure am. And I'm planning on doing some live courses also. And so pretty excited about that. Let's talk lumbar spinal stenosis now. I'm going to be peeking off to the side once in a while because I can't get this PowerPoint on my computer and do the webinar at the same time. So please forgive me. And I'm going to do my absolute very best to use models, okay, and to show you what it is I'm talking about. So let's just get oriented with a little bit of anatomy here first, okay? So if you take a look, here's the vertebrae we have. We'll call this L4 and L5. And in between you have the disc, and look at how nice and juicy that disc is, okay? What the disc does is it helps to keep the house off the foundation here and keep it elevated. Now, posteriorly, we have the facet joints. The facet joints also help to hold the posterior aspect of the vertebrae up. And what's in the middle? Okay, in the middle, we have this foramen, this circle that is around the nerve root. Okay, now if you take a look down the spine, okay, you have the spinal cord and canal, and you can see the hole around the canal. It's nice and clear, nice and patent. And so what stenosis is something that closes around it. So like this pen right now, you can see there's a hole around it. As I close down, that's called stenosis. You can have central cord stenosis, or you can have foraminal stenosis, okay, where the something is filling up this hole, okay? Now, what I want you to recognize here is that on the most upper vertebrae, you have a semicircle here. On the lower vertebrae, a semicircle here. So they essentially do this, okay? As the vertebral bodies come closer together, so if the disc starts to degenerate and it starts to get thinner, you can see how that hole would now start to close up a little bit anteriorly. If the facets back here where my thumbs are starting to break down, you can see where the hole would start to get smaller there also. Foraminal stenosis, that's what that is, okay? So not only does the house collapsing on the foundation in the front and in the back cause stenosis, but something else can take up space, okay? So the disc can herniate out the back, cause an occlusion and cause the space to be smaller and give pressure on the nerve root to give pain down the leg, okay? The other thing that can happen is you can develop some osteophytes and arthritis in the facet that starts to push back a little bit and take up space posteriorly. So you can see how now the hole is getting smaller when we are starting to take up some space back here, okay? And that's called foraminal stenosis. So what I want to talk a little bit about is, positioning. What causes this and what are some of the factors, okay, that make this worse? And I think I'd be best to try to explain this with my big spine model here, all right? So we have anterior and we have posterior here. Okay, so imagine this. Imagine if we take the spine and we bring it into extension. All right, and you take a good close look here. I'm going to try to bring this in as close as we can. All right, and take a look at what happens to the foramen where my little finger is. If we flex forward, it opens up. If we extend, it closes. Okay, so think about the things that cause extension of the lumbar spine. Okay, if you have a large belly and that belly is pulling you forward, you're going to have an accentuation of your lordosis and the foramen are going to start to close. Okay, if you bend forward, it's going to open up those foramen. So when I say big belly, okay, if you're a little overweight, that can cause some of that to happen. If you are pregnant and your belly is coming down this way, it's going to cause you to go into what we call an anterior pelvic tilt. When this pelvis starts to tilt anteriorly like this, you see what happens to the spine. It goes into extension. So imagine what happens if your hip flexors down here are tight. They will cause this to go forward. If your abdominals are weak, you go into an anterior pelvic tilt. If your hamstrings are weak, they push you, they allow you to fall into anterior pelvic tilt. Okay, so if you think about this, this is what causes spinal stenosis. All right, this extended posture that closes the foramen. So think about it. If we could strengthen the abdominals, we would go from here to here. If we could stretch the hip flexors out a little bit, it'll also take you from here to here. If you strengthen the glutes rotate you posteriorly, okay, and help to open up those foramen also. Not only does it open up the foramen, but it also helps to take pressure off of the facet joints. And all of these things also help spondylolisthesis, which is a slippage of the vertebrae on top of another vertebrae. So what we talk about today can also be utilized with people who have spinal stenosis. All right, spondylolisthesis. All right. So when you evaluate somebody, you want to make sure that you get this diagnosis right, because this is not just like having a herniated disc where, you know, the herniation is pushing out posteriorly. And a lot of people have this tendency to put people into extension programs. Well, if you miss this and you say, well, we think it's a disc problem, but they actually have spinal stenosis, you're going to find these people are going to get worse if you put them on a McKenzie extension program. So you're going to be wanting to do flexion biased exercises to help open up the foramen. And sometimes doing a little bit of flexion can actually pull the disc material away from that nerve root and give you some relief. All right. So when you are evaluating the patient, you know, do a very thorough evaluation. Check out their hip flexors. Are they tight? Do they have an accentuated lumbar lordosis? Do they have a tight thoracic spine? Okay. Because of this, if your individual vertebrae and your facet joints are very, very tight. Imagine me taking a rod and screwing it into the spine and not allowing those vertebrae to move independently anymore. Then what happens is when you stand up, you're going to extend. And if your thoracic vertebrae don't extend very well like this, all of the pivoting is going to come from the lower lumbar spine. That excessive pivoting is going to cause more stenosis. Okay, so people with a thoracic kyphosis like this, and it's very, very rigid, when you mobilize that, they're at high risk of having spinal stenosis. All right. An x-ray can be helpful. And why can it be helpful? Number one, it can identify some arthritis in the lumbar spine. But when you do an x-ray to the lumbar spine, I'm pretty big on having a standing x-ray with a lateral view. Okay, so a lateral view while the patient flexes and while they extend. Okay, that would show us if they have any instability of the vertebrae and any sign of listhesis. Those can contribute to spinal stenosis. Okay, if you come up with a diagnosis of spinal stenosis, you need to be very clear in your explanation of what it is and how difficult it is to treat, because this is a structural problem. Okay, it's like your car being out of alignment and your tires wearing out. Your tires are going to keep wearing out no matter how often you change them, unless you change the alignment. So if we as therapists can change improve their flexibility and improve their strength to get them out of that anteriorly pelvic tilted position, they should do better. But you have degenerated discs. Those aren't going to grow back. Okay. So like after 25 years old, they start to get smaller and dried up. So the house is already collapsing on the foundation. The facets start to break down. We're not going to rejuvenate that joint structure, but we can make a difference with the soft tissues around it and try to change the position. So in my opinion, about 25 to 50% of people will get better with conservative therapy when treating spinal stenosis. Some require an injection if they're getting a lot of isolated foraminal encroachment. They could get an injection to decrease chemical irritation or chemical inflammation in that area and swelling. So that can be helpful also. But remember, this is a very structural problem. So sometimes they need to resort to surgery to have this fixed. So I'm just going to change pages here. How's everybody doing? I know I'm going to shoot out a lot of information. I talk a lot and I talk fast. I'm going to try to slow down a little bit. So clinically, what are some of the signs and symptoms of spinal stenosis? So when you talk to your patient and you ask them questions during their evaluation, there's a couple things you can ask them that can really help drive you in a certain direction to try to identify what their back problem is. There are all kinds of back issues out there. In my opinion, there are some caused by too much extension, some caused by too much flexion. There's herniated discs, there's spinal stenosis, there's arthritis. And I think it's pretty much as simple as that. Very few people come in with mechanical low back pain, actually. There always seems to be a problem that is deeper than that. So, first of all, I ask the patient, where are your symptoms? Where do you have pain? And typically what they'll say is I don't have pain when I'm sitting, but when I start walking or I stand for a long period of time, I may have pain that goes down into my buttocks, into my hamstrings, sometimes down into the calves. Usually, though, they'll have pain localized to the low back. That's kind of where it starts. But once they start walking and they start standing more because you're closing the foramen, they start to develop more radicular type symptoms. Oftentimes it's both sides, but it can be on one side. So don't let that fool you. They can also have paresthesias associated with that, especially if they're up and standing. All right. The pain usually follows a dermatomal pattern because they have neurogenic claudication. If it's nerve related, it will follow a dermatome. So they might say the big toe is going numb. I'm getting pain in the outside of my calves or the inside of my knees or down both glutes, down into the SI joints. Those are dermatomes. If the patient says, you know what, I'm having pain only in one leg and the whole leg is getting heavy and numb and tingly, you need to be thinking vascular. Okay, so that's how you can differentiate between the two. And we'll talk about vascular in a little bit because we definitely don't want to miss that. I asked this question, and this is very, very helpful during my evaluation, and you're going to find this kind of funny, but it works. So the patient comes in and they say, yeah, I have pain, blah, blah, blah. I say, okay, you go to the grocery store and you grab a basket. How far do you get? And they'll always say this. They'll say, oh, I get like to the produce section and then I can't keep walking anymore. But if I take the cart and I bend over the cart a little bit, I can walk around that store 10 times, never have a problem. That is a classic sign of neurogenic claudication and spinal stenosis because they're forward bent, the foramen's open. They're getting nice impulses to the legs. When they stand up with that basket in their hand, they're getting closure. They're getting compression of the nerve root and giving them pain down the legs and some localized back pain, and it's quite uncomfortable. And then they'll say this. And then you ask them, so when you go sit down, when it hurts, or bend forward, does it give you relief? And they say, yes, it gets better right away. And then they'll say, I sit for 4 or 5 minutes and then I can get up and I can walk the same distance, but then I have to stop. And it's always at the same distance. That's a very classic sign of neurogenic claudication and spinal stenosis. All right. And the other thing is that if you're a PT or a physician and you're just doing a little assessment, excuse me, it's kind of hard without a bench here, and you do a PA mobilization. When you push down on the spinous process, you bring the spine into extension, as you can see here. Okay. And that closes the facets. It gives irritation to the facet, but it also gives some closure to the foramen, as you can see right there. Okay, watch this. You bear down on it, it closes that foramen and causes irritation. They're quite uncomfortable. Then you keep working your way up here, and you're going to notice that this is going to be very, very rigid. That's classic with almost all of them. Okay, so I have a nice video that I'm going to send you as a link to my YouTube channel with somebody who has classic neurogenic claudication. And what happens is, as they walk more and you kind of push them, they'll get a little sloppy in the legs. So the way I assess them in the clinic is I have them walk with the shoulders back, nice and upright, nice and straight. And then I assess how they do after a couple hundred feet. If they can walk, 1,000 feet and they don't have like the increased radicular pain down the legs and the aching and the burning and loss of control of their legs, I'm not too concerned about that. But usually they'll get in 400 or 500 feet and the things will get kind of achy and sloppy. And then I'll have them walk in a slouched position, just like this. I'll have them walk like this. And what you'll notice is that they'll have some relief and they'll be able to continue walking and do really well. So when you are doing your physical assessment of your patient, here's something that people miss all the time. Okay. So you typically like to do reflex testing, sensation testing, a straight leg raise, and some manual muscle testing. All right. And what is the position you always test them in? I'm going to sit on my desk here, so bear with me. Okay. So what you do is you put the patient on a desk like this. Their knees are bent and they're sitting upright. So when you take their leg out here and do a straight leg raise, they typically say, yeah, I don't have any pain going down my leg. You're going to check their reflexes, and the reflexes may be fine. You're going to check their sensation, and it may be fine. And you're going to check their distal muscle strength, and it may be fine. And you're thinking to yourself, well, they don't have nerve root compression. Remember this, when they're flexed, the foramen is open. The nerve is not getting compressed. Okay, so that can be very deceiving. And what can happen is you'll find that these people with spinal stenosis may not have those other neurological symptoms that people with a large herniated disc have. So keep that in mind when you're evaluating your patient. So I'm starting to assess people laying on their back with their legs off of the edge of the table so that they're getting some compression. And typically they'll get some numbness and pain down the legs and things like that. That exacerbates and closes that foramen. So that's something that you should really take a look at. But don't let the no reflexes, no sensation, no strength or good strength in the legs throw you. Okay. Something you want to do is make sure that you don't miss a vascular claudication. Okay. So what is the difference between neurogenic claudication and vascular claudication? Number one, vascular claudication will cause a global dead, quote unquote, here my air quotes, quote unquote, a dead or a achy pain in the leg. Okay. It is not relieved with flexion, and oftentimes it is actually exacerbated by that. It's reproduced on a stationary bike. Now, remember, when you're on a stationary bike, you're forward flexed. So if you had a neurogenic claudication or a spinal stenosis, the foramen are open when you're on a stationary bike, right? And so if you are on a bike, the foramen are open. It's not coming from your spine, but you're biking and your leg is becoming very heavy and very achy. It means the leg is not getting blood flow. Okay. And that is a sign of vascular claudication. And then they also will have a loss of pedal pulses. And sometimes the leg will get white following the activity. So you get them off the bike, they're really achy and they're ugly, and you put them on a table, you look at their foot and it's like stark white. You have to be thinking vascular claudication. Okay. The leg will get cold quicker than the other leg, and it's more common on one side than the other. You can have it on both sides. I had a next door neighbor who just had vascular claudication on both sides, which we picked up, which ended up leading into not only claudication in his legs, but they found it in his heart. So they did surgery and he's doing much better. Sometimes these people can also prevent with weakness and foot drop in the legs. So with vascular claudication, so don't miss that. Those are the differences between vascular and neurogenic claudication. What can you do to treat this? Okay. This is going to be a little trickier to do because I had some nice slides. You'll see them when you get them. I'm going to send them to you. But so think about it. We talked about, and I'm going to see if I can kind of hold this up. Okay, we're gonna put the patient on their back. We want this spine to go from this position to this position. Okay, so we're in extension right now. If we strengthen the abdominals, it's gonna take the patient into relative flexion of the lumbar spine. Okay, so little crunches, partial sit-ups, transverse abdominis contraction exercises to stabilize the lumbar spine so it's like this, and when they do activities they don't fall back into extension. Okay, the other thing I like to do with patients is flip them on their stomach. Okay, and I like to put an arm over them or lock this down somehow while they push back into extension. Okay, don't let this deceive you that it's the head's on the wrong side. So you want to try to get them to extend above the area that is stenotic. So we want to try to get these individual vertebrae moving better. So I will change where I lock them up, and you'll see in the video how I do it manually. You can also use a strap to do that also. I also like to do PA mobilizations. So I get on the spinous process and I work everywhere above the area of stenosis. The stenosis most often happens between 3, 4, 4, 5, 5, and S1. So I stay above that and I mobilize the spinous process anteriorly, and that helps to improve the extension of each vertebrae. And once we get these loosened up, you'll be surprised. Your patients usually get up and say, hey, this isn't bothering me so much. You know, I can walk a little bit better and I feel a little bit looser. The other thing you want to do is you want to stretch the hip flexors. Okay, so if you're really tight in the front, you can see this is the femur, this is the pelvis. If your hip flexor is my hand and it is really snug and tight, it's pulling you forward like this. Stretch the hip flexor. All right, I've got a video how you can do that manually. I like to do a kneeling hip flexor stretch or a standing hip flexor stretch so that you're kind of like this. Okay, one in front of the other. I prefer to do it with one knee on the floor. It is much better. You can get a much better hip flexor stretch, and that can be very helpful so that it releases the pelvis into a more posteriorly pelvic tilted position. Okay, and then I like to do glute strengthening. I do a lot of leg strengthening and a lot of glute strengthening with my stenosis patients and all my back patients, because if you strengthen the glutes, you're going to posteriorly pelvic tilt that pelvis, and then you're going to take the spine into relative flexion, and it stays more in a neutral position. Okay. I'm big into cardio. The spine does not have a lot of great blood flow to it. After 25 years old, your discs start to lose vascularity to them, and your discs start to dry up. One of the ways to get blood flow and nutrition to it is through movement and sloshing of fluids around your vertebrae, and a little hydrostatic pressure helps to absorb it and release it. So movement. I'm big on cardiovascular activity. And I know that some of the surgeons that I work with, the neurosurgeons that I work with, are also big on also doing cardiovascular activity to get those avascular areas, you know, kind of working a little bit and get some nutrition to them. So how do you know when you're treating a patient if they have met maximal rehab potential? Well, number one, they have no change in their pain level. Okay, so you work with them for 3 or 4 weeks. You've been doing all the mobilizations. You've been doing stretching of the hip flexors, strengthening of the glutes, and you're working on the abdominals, and they just are not. They're still having that pain. You know, that's one reason. Number two, they cannot walk any further. Okay, so they've go to the same distance every time, and they have the claudication and pain. So that is another reason why you have to start thinking, well, maybe you will not be able to help them conservatively. They continue to have a flexed posture, and medication only gives them temporary relief. Okay, so you take medication, yeah, I feel good, but after a couple hours, it kind of comes back. It's because you have a mechanical issue there. So I've had a lot of conversations with neurosurgeons who work on lumbar spine issues, and they've given me this direct feedback. I say, okay, so when is a patient a neurosurgical candidate? Okay, so number one, if the patient has a true diagnosed spinal stenosis, and you can identify this in the clinic, you can identify it with x-rays, and most oftentimes the best way to do it is by MRI. So if they have true, frank, lateral foraminal stenosis, the foramen is closed up, or central cord stenosis, and you see that and it's measurable, that's an indicator for surgery. Number two, if they have Neurogenic claudication, heaviness, burning in the legs, usually with ambulation and being in an upright posture, that's another sign. The other big one here is a red flag called cauda equina syndrome. Patients who have saddle paresthesias, or they start to become incontinent, they lose bladder function, and they have difficulty starting urination, erectile dysfunction. Those types of issues, those are surgically urgent patients. You've got to contact a neurosurgeon, say, these are the symptoms. We've got to get this patient in quickly. The neurosurgeon will ask more questions and then kind of expedite things from there. I always recommend trying to connect with neurosurgeons and really knowing what they want, okay? Because you don't want to just send patients for nothing to them. You want to send the right types of patients to them because they're neurosurgeons. They want to do surgery on people. They don't want to manage somebody who's had chronic myofascial pain for 10 years in the lumbar spine and they haven't tried therapy, medication, or injections or anything like that. So those are the indicators. Typically, these people will do okay with an injection, like a transfemoral injection. But the problem is that, it's a mechanical issue. So you can't really change the bony structure. You're only going to change the chemical irritation there. And that usually is temporary. The good thing about getting an injection, though, is it can be diagnostic. So if you do an injection at, let's say, an L4, L5 transforamen, and they get great relief for like 4, 5, 6 days, but the pain starts to come back when they're walking, you know that they have a structural issue there. Best thing about it is if the neurosurgeon knows that, they know exactly where to go. So they match that up with their clinical exam and the MRI and X-ray. Boom, you've got a nice target to go to in surgery, and the patients do really well. So these people who have radicular pain do really well with neurosurgical intervention. And so, again, don't forget to get those flexion and extension X-rays because that could be very helpful to identify if they have some sort of instability there. So that is lumbar spinal stenosis in a nutshell, okay? In my opinion, it's very easy to identify. I'll do a couple pointers here. Number one, it's worse when they're standing and they're walking. Number two, they do much better when they're pushing a cart and bent over than they do when they're walking with a basket in their hand. Okay. Number three, it causes them discomfort down a dermatome, usually down the legs, and can be quite uncomfortable. Number three, can be identified in people who have excessive kyphosis, a very stiff, rigid thoracic spine, people with an accentuated lumbar lordosis. And one last thing that I want to throw out here, this is very, very common, okay? And I don't know if this has really been researched. So if anybody out there gets excited about doing a research study, this would be a great one. I find a significant correlation between spinal stenosis and people who have hip arthritis, because if the hip is arthritic and it doesn't extend very well, it thrusts the pelvis into anterior pelvic tilt, jamming the facets and closing the foramen in the posterior lumbar spine. So not only do I look at that lumbar spine and I do everything we talked about in this webinar today, but I also assess the hip to see how tight and see if they have any sort of intra-articular dysfunction, tightness there that is causing them to have this limited range of motion. And it's amazing. Sometimes people have so much hip arthritis that it causes them stenotic type pain in their back. They get an intra-articular injection of the hip and sometimes the back really settle down. So don't miss that. I will be doing some videos pretty soon on common red flags around the lumbar spine, referral patterns in the lumbar spine, what can cause lumbar spine referred pain, and many other things. If you like this, I really would like some feedback on this. If you hate it, I want some feedback on it. If there's anything you'd like to see different about how I did this webinar, please include it. I'm really a kind of a practical type of guy. So I think future webinars will probably be done in the clinic with a table, with a model demonstrating different activities. I want to get back to the basics of a lot of this so that you can get more comfortable. But if you have questions about spinal stenosis, anything I might have missed, maybe a treatment programs, that type of thing, or you have a request for a future webinar, I'd love for you to contact me at orthoevalpal.com and go to the website, go to the Get in Touch page, and make sure that you get onto that. You'll get all of my podcasts whenever they come out, and I'm actually starting a lumbar spine series coming up soon, and also going to be having a couple guest lectures regarding the lumbar spine and the hip. And so that's going to be exciting. Plan on doing a lumbar spine course coming up in end of November, early December. I would love to know if you are interested or not. And please spread the word with your friends about Ortho-Eval-Pal. I'd love to, I'm getting so much growth right now on my YouTube channel and through the podcast. It's been spectacular. So, if you know of anybody else who wants to learn more about orthopedic evaluations and how to treat certain orthopedic problems, please have them jump on, and I will get them as much information as we can. So thank you so much for listening. Again, I apologize for the last webinar not going live, but I will send you all this information, some links. I'll send you my PowerPoint presentation, and thanks again for joining. Take care.